Good morning, good afternoon, and welcome to today's webinar with Drs. Austin Snowden and Ann Vandenhoek titled, What Happened to Chaplains During the Pandemic? An International Perspective. I'm Andrew Dresco, Project Coordinator for Transforming Chaplaincy, and we're delighted you could be with us today. Just a quick word to thank our co-sponsors, both the European Research Institute for Chaplaincy and Healthcare and our good friends at the Chaplaincy Innovation Lab. Just some tech questions from the get-go. You'll notice in your dashboard that there's a box for questions. So at any time during the event, please feel free to type those questions in the queue, and we'll try to get to the Q&A towards the end of the event. And if you have any technical questions for audio visual, feel free to use the chat box and I'll be monitoring that. And without further ado, I'll turn this over to Trace Haythorne, the CEO and Executive Director for ACPE, the standard for clinical pastoral education. Trace?
Thanks, Andy. It's good to be with you. It is my pleasure to welcome you all to this gathering today. This research project will lead to a special edition of the Journal of Pastoral Care and Counseling. Journal of Pastoral Care and Counseling is celebrating its 75th year, and we'll give you more details about that edition. It should be out in the next few weeks. But it is my pleasure to introduce our two presenters today who were two of the leads on this research study. Austin Snowden is the chair in mental health at Edinburgh Napier University. Austin wrote the lead article for what we're for the journal edition, and Ann Vandenhoek is an assistant professor in pastoral care at the Academic Center for Practical Theology and Religious Studies at the University in Leuven, Belgium. It is a delight to have you all here with us today. We hope that if there's opportunity, we will be able to offer some time for questions at the end. And we hope that if you've not had a chance to explore the European Research Institute for Chaplaincy and Healthcare, know that they are the sponsor of this project and brought us together. We had a team from the US, from Europe, and from Australia that worked together, with the leads being our good folks from Europe. So thank you so much to Austin and Ann, and with no further ado, I will turn it over to them, and then we'll have a response from John Overbold, who is the current president of the Association of Professional Chaplains, serving as a part of NYU. Thanks so much.
Thanks very much, Trace. Can you hear me okay?
Yes, thank you.
And can you see the PowerPoint presentation there on the screen?
Yes, you're in good shape.
Okay, just checking, because all I can see is my screen, of course. So thanks for inviting us to the webinar. It's been a lot of fun putting this together, and actually the whole work was a lot of fun with our international colleagues, including yourself there, Trace. So what we're going to talk about is the survey itself. First, a brief look at the context, which everyone is pretty well aware of. Then look at the background and the aims of our survey, and then the method for talking about the aims. But we'll focus on the results, and I'll talk about the quantitative results essentially. And then we'll look for an explanation of some of those quantitative results, looking particularly at the free text, and Anne's going to focus on those elements. And then we'll have some questions, hopefully enough time to answer some of your questions at the end. So this is the context. I'm sure I don't need to tell anybody what the context is. That was the situation back in August 2020, internationally. 702,000 deaths, and that was just back in August, with 18 million confirmed cases. Fast forward to where we are today, and just last week there were 2,287,000 global deaths, with 105 million global cases. This has been absolutely massive. So that's the context against which we thought, I wonder what was happening to chaplains in this. The world is changing incredibly rapidly at the moment, and we thought people would need chaplains more than ever. Having said that, we do know that others don't know what chaplains do at all, and the evidence for the outcomes of chaplain interventions is still weak. So the pandemic could have either been absolutely catastrophic for chaplains and their patients, or it could have presented a unique opportunity. And so against that, we had our aim to understand how chaplains delivered spiritual care during the COVID-19 global pandemic. And the two objectives that we'll discuss today are to describe how healthcare chaplains delivered spiritual care during the pandemic, and to identify the key changes to usual practice and examine their impact on chaplains, patients, staff, and the wider culture. So, I won't go through all this. This detail will be in the publications that will follow, and we'll talk about this. But essentially, we broke our objectives down into survey questions. So we started off with, demographics for the first ones, whether they had access to COVID patients or not. The interesting stuff from our point of view was, once we found out what our sample was and who was in our sample, was wanted to understand how clear their role was, whether they were supported or not, whether they felt they could have been better deployed during the pandemic, and feeling questions at all, whether they were anxious or afraid, whether they felt the organization limited access to COVID-19 patients. Talked about self-care of chaplain. So were there any changes to usual practice? So we wanted to know how the chaplains took care of themselves and whether that was different as how they would usually take care of themselves. And in relation to what they did the organization understand the chaplain contribution? And then into the free text for the chaplains, which issues had the greatest impact on you? Were other staff delivering spiritual care? Was your professional association supportive? Was your faith and belief group supportive? And how do you think this pandemic has changed our profession? So quite a substantial questionnaire with a good range of responses as well. This presentation will just focus on these questions here. So we'll talk about demographics briefly. Did your work setting change during the pandemic? Did you have access to COVID patients and non-COVID patients? And how clear was your role to you over the months? So from, we call it the beginning of the pandemic here for the survey. So it was January and February through to May. We're going to discuss supervision and support. Do you feel whether you could have been better deployed? So that's a reflection on how chaplains felt about their organization treating them. And then what had the greatest impact on you, and how has the pandemic changed healthcare chaplaincy? So probably about just a reasonable amount of the survey, but as just a selection of questions. So we disseminated the survey worldwide through this organization, through the Association of Professional Chaplains, our US colleagues, our European colleagues, our Australian colleagues, and we sent it out to all chaplains that everybody knew in our network. So we got back just 1657 completed surveys, and you can see the breakdown here on the bottom. The vast majority were from Europe, North America, Canada, and Australia. We had a few from Asia and a few again from Africa and South America, but the bulk of the responses were definitely Western. So this is just a graphic of the international responses to the survey. As you can see, we've got the majority from Australia, Europe, and of course North America and Canada there, with just a few outliers, just the one person on the African continent, which we're very grateful for. The mean age and mean numbers of years in service was pretty much the same. Maybe you could say the European chaplains are younger at the mean age of 53 as opposed to 58. And the Australian chaplains were perhaps less experienced as chaplains, having had about 9 years of service on average by comparison to the more experienced European and North Americans. I'm not including these guys in the responses here for fear of potentially identifying them. So I'm just focusing on the Western responses. In terms of gender, you can see the breakdown here. The blue is female, and so the majority of respondents were female. The education by level was quite interesting in that the majority of North Americans are master's degree level, as are the Europeans, whereas by contrast, Australia was more bachelor degree level, and of course America had the greatest number of PhDs as well, so just down to the 8 there in Australia. Although remember, this sample is 200 as opposed to this one being 660 odd. In terms of religion, the breakdown was majority Christian Protestant, supported with Christian Catholics second, with the majority of the humanists being in Europe, a few there in Australia, and the Jewish community almost entirely in North America. So I just thought that was interesting by way of breakdown of the religion. I don't expect you to see that. It's just a picture of the table which is in the publications, but it breaks down these demographics I've just shown you a little more, a little further. So just a reminder of the questions that we're going to look at in this presentation. Did your work setting change during the pandemic? Did you have access to COVID patients and non-COVID patients? How clear was your role to you by months, starting from January and going through to May? Did you have regular supervision or intervision? Do you feel you could have been better deployed? What had the greatest impact on you? And how has the pandemic changed healthcare chaplaincy? These are the questions that we're going to look at in this presentation. So, work setting. Which setting do you usually work in, and which setting did you work in during the pandemic? We asked this question just to see if there's any displacement of chaplains over the first few months. And so this diagonal line are those chaplains who, for instance, here is they started off in mental health and they stayed in mental health. Here, 780 started off in hospital and stayed in hospital, but 3 of them moved to a nursing home and 14 moved to other. So the key thing to take away from this particular slide is just that the vast majority of chaplains stayed where they were. Did you have access to patients during the pandemic, both COVID and non-COVID patients? We had a series of responses to this saying, from being allowed in the room or only having access to family members or through technology. And only a small amount of people were allowed into the room. So only 8% were allowed in to see COVID patients. That's not surprising at all. Only having access to the family members, okay, similar sort of percentages to the first one, but obviously through technology, there's just been a massive uptake in technology usage in chaplains over the period of the pandemic. It's interesting that I guess they would stay the same, the non-COVID patients. Now, how clear was your role to you? I think the key point is to say that's the neutral score. So none is completely unclear, whereas 4 is completely clear. Okay, so how clear was your role to you in January? The blue line is Australia, the orange line is Europe, and the light grey line, North America. And I think that you can see a drop in clarity for both Europe and North America, but it picks up again there, but it doesn't get particularly high. So overall, I'd say there's a little drop and then it returns back to normal. And they're only in between neutral, and they're certainly not clear, are they? So all the way around, you know, the most optimistic interpretation you could possibly put on that is that chaplains were neither clear nor unclear about their role during the pandemic and at the start of it as well. So that's quite interesting. Many countries hadn't actually started in the pandemic at that point, and yet, you know, they were still unclear about their role. Did you have regular supervision, intervision, or other group reflection? And this is just about support. And don't forget, these are numbers again, so they're not percentages here. So you have to take that into consideration when you look thinking about the Australian responses, because their pattern is essentially similar to the European pattern. And I think you can say most chaplains, at least, were supported sometimes. The majority were often and very often. So the formal support looked to be quite good. There was just this group down here, the minority really, that wasn't supported very well. Do you feel you could have been better deployed? I think the red circle is the yes. The green is the no, and the reason I put it that way round is because, you know, the yes is the kind of dangerous response, isn't it? You know, so you've got all these chaplains who responded to this question, and the majority of them, possibly, you know, an average of 2/3 and more, are saying that they felt they could have been better deployed during the pandemic, which is very significant. You know, they felt like it obviously sort of difficult to interpret that, and I'll talk more about that, but it's, you know, it suggests that a lot of them felt like they weren't necessarily doing the job they felt they could have done. So some explanation for that is, and these are quotes from the responses to support these questions, the free text follow-up. Chaplain leadership should have been at the executive leadership table during discussions of how to manage the pandemic, how to address patient isolation, family anxiety as a result of absence from their hospitalized loved ones. And another person said, although we say that chaplains are integral team members, chaplains were not part of the discussions about both COVID and non-COVID patient care management at the outset. This should have happened. And lastly, on this slide on the right there, chaplains should have been involved in more indirect patient care throughout the pandemic. The attitude of leadership and nursing seemed to be that everyone beside doctors and nurses would spread COVID. So everyone besides doctors and nurses must be excluded from encountering COVID patients. And this resonated with another few of the chaplains who felt there were little more than an infection risk at the beginning of the pandemic. What bothered you the most? For all the chaplains, the social distancing was the main issue for them. And that's possibly related to the second one for everyone, which was the dignity of patients. And the third most troublesome element was not complying with the criteria for a good death. And that sort of correlates with the other high response there for care for deceased patients. Now, I do want to point out that, you know, this scale doesn't start at 0. So these results, they look further apart than they actually are. All of these things bothered the chaplains. It's just that, you know, the thing about shortage of materials bothered them relatively less, and shortage of material to treat patients. So just something to bear in mind when interpreting that slide. I'm now going to hand over to Anne. Anne, I'll keep on flicking the slides when you tell me to.
All right, thank you, Austin. I first want to thank everyone of you who is tuning in and has participated in our survey. Thank you for your time because when we come to the free text analysis, there is this wealth of information that we gathered through the free text questions, which was intimidating at the beginning. We also invited people to answer in their own language. So in the beginning, we translated a lot of the answers into English so we could have a look on all the answers. And next slide, Austin, you will see that we had 44,000 words in the free text boxes, which was quite impressive, and which was indeed coded line by line. 10% of the respondents answered there in a language other than English, so that's good to know. Let's move on. Now, I just can't tackle everything during this webinar of the free text boxes and questions, open questions. So we'll pick some things and we'll invite you to read the rest in the open access issue of the Journal of Pastoral Care and Counseling. I just want to focus on some of the key changes for chaplains during the first wave of the pandemic. And that's really important to understand that we're talking about the first wave of the pandemic. Meanwhile, some things have changed, and I think it's good to start a reflection about what has changed and how that has changed. But back then, and we're talking about March, April, May 2020, the following things were key changes for chaplains in their spiritual care. First of all, chaplains answered us that they felt challenged to the core in their spiritual care. And the majority of chaplains answered about, what have you lost in your practice? They answered with physical presence. And physical presence, of course, refers to distorted connectedness. Chaplains were not allowed into patient rooms or resident rooms, or had restricted access. There was not enough protective gear in the first pandemic wave, or indeed, as Austin mentioned, managers thought that they would spread the virus, or managers made decisions, as many chaplains answered us, on the basis of, lack of knowledge about what chaplains could contribute to the whole of care of patients. And so the physical presence referred for many chaplains to actually being in the room with patients, residents, or family members, but also referred to having to wear a mask, or even referred also to a part of what you need to understand someone's story that is missing, because you don't see verbal expressions or non-verbal expressions, I'm sorry. So there was like this physical component that was lacking, that was missing, that challenged spiritual care to the core. That was the first group of answers that we could distinguish. The second group of answers, we thought we could group it under the title Shared Spirituality. Chaplains felt challenged because they could not have shared spirituality time or moments with residents, patients, or family members. And this goes from rituals at the bedside to discussion groups on the meaning of life in mental health, to celebrations or liturgy in chapels or sacred spaces. This was the whole range of we share spirituality with one another in healthcare facilities, and this is no longer possible. The third group of answers about what challenged chaplains to the core in the first wave of the pandemic was the general feeling of we are not able to do the job as we should. And this, for most chaplains who answered on that question, went very deep. They were suffering underneath the fact that they could not do their job as they were supposed to do, as they wished to do, as they're used to do their job. So that was kind of a tough thing for them to report on. And this is about, not, as Austin also mentioned, not being able to provide end-of-life care the way we used to do it. Not being able to, for example, work in teams the way we used to do that, work interdisciplinary in the way, not to care for patients the way we used to do. And knowing that at the same time, a lot of patients and residents are experiencing existential loneliness, are dying alone, and still not being able to do your job, while it is very much needed. Chaplains suffered from that, and they also expressed that with concepts like moral injury, for example. And that's why we decided to do an article on dealing with emotions and self-care in the Journal of Pastoral Care and Counseling. There were no direct questions on that in the survey, but in the open text boxes, we found a lot of things referring to that. So we included that in the journal. Well, that was kind of the key changes in spiritual care, the three major groups. There are others, but these are the three major groups. And I want to go now to the fact that chaplains also turned out to be resilient and creative in a changed context. They found other ways of being present. And of course, everyone answered, or almost everyone answered or mentioned new technologies, being in contact with patients, residents, and family members through new technologies. And there was a range of technologies that were mentioned. And it had pros and cons. As we all know, it's easier to get in touch with family members virtually than it used to be when we didn't use new technologies. So that is something that chaplains want to retain after the pandemic. But it also had cons, like, for example, if older patients, older residents are not that savvy with new technology, needed help from nurses or physicians in the room. And then, of course, the question arises, what about confidentiality? So there are pros and cons to using new technologies, but chaplains massively went that way. We also see that the majority of chaplains is talking about staff care. If we're not able in the first wave to visit patients, residents, be at the bedside, we turn our care to those who do. And there was a lot more time dedicated to staff care. And this had some consequences. Some chaplains were writing, because of our staff care, staff experienced the meaning of spiritual care. And thus we were called back to the bedside of patients and residents. So it had an impact. And a lot of chaplains here describe that they became intermediaries between patients and residents and their family members. And they were at the same time being innovative, for example, on the level of rituals, initiating new rituals that took into perspective the distance, the social distancing. For example, doing a ritual in a sacred space or a chapel for someone who was dying with the family members while the patient was a few units away. And there were lots of creative things, symbols, use of new things that were done there. But intermediaries, for example, chaplains who took pictures of the hands of patients and sending them to family members to give a sign of life. There was a lot of resources that were used. So this is very uplifting to read how creative, innovating, flexible, resilient chaplains have been during the first wave. And then, of course, I think that we have to think about the fact that all of us in the international team were stunned by the difference between chaplains. There was on the one extreme, there were chaplains who were made redundant during the first wave of the pandemic, who were sitting at home because they were not needed anymore got that message by management or whatever. And on the other extreme, there was the group of chaplains who came out of the first wave of the pandemic more integrated, integrated in policy making, in staff care, in decision making, in patient care. And then there was a larger group of chaplains who were in between. And we have been wondering about the difference between those two extremes. And one of the things that we're very much stressing as a result of this survey is the need for advocacy for chaplains. And we don't want to put as we wrote also in the open access issue, we don't want to put the blame on chaplains. That's not what it is about here. I think that when chaplains are made redundant, there are other factors in play. There are multiple factors in play, but then just, maybe lack of advocacy. But we see from this survey very much that we need to be prepared more and more and need to invest more and more in leadership skills and in advocacy skills. And we describe this also a little bit more in an article on education, because I think that COVID-19 will have an impact and should have an impact on how we educate and prepare chaplains for pandemics and major disasters. So this is something that we delve deeper in that article. An increased knowledge of technology, but new competencies that go with spiritual care in a disaster like this pandemic and maybe future pandemics. Next slide, Austin. Here you see some vignettes that we took out of the open text boxes, talking about what was very hurtful to chaplains, as you can see, but also what was kind of creative and innovative and new to chaplains. During the pandemic, I switched to providing spiritual care almost exclusively over the phone to families, which is the inverse of how I was spending the bulk of my time before the pandemic. And here you see an illustration of how much influence the pandemic had on daily spiritual care practices. Next slide, Austin. I already talked about that, so that's good. We can go to the next slide. I think that we just, we think that there is more research needed into certain aspects. It would be very much interesting, of course, to do a second survey and to see how the second wave, and for some even the third wave, has impacted spiritual care and what has changed. But I think that it would also be very much fruitful to have more research into what can we take away from the pandemic that will support our integration as chaplains. And it's not about preserving our profession for the sake of our profession, but it is for the sake of the best possible care for patients, residents, and family members. How can we secure that part of care based on what we did, what we experienced, what we learned from the pandemic? And I think that this survey wanted to contribute to that, and I hope that it did. I just want to leave it at that. I think that we have taken our 30 minutes. There is a lot more to say, but I just, like Austin, want to thank everyone in our international team, especially also, the Australian, the US part of our team, and you all who participated in the survey. Thank you so much. And we're open now, I think, to hearing John's response.
Great. Thank you. Thank you so much, Anne and Austin. Very excited and pleased to be here and to be asked to respond. This research, I think, is very commendable for the rich information about the role of chaplains in this pandemic. And I especially appreciate the speed with which the study developed the research question and launched the survey to be able to now to digest insights from the first wave is really remarkable. What I recall about this period for myself serving in New York City in a teaching hospital was this rapid speed of change in practice that occurred almost daily. And in my hospital, there were daily briefings, videos of the chief executives, and daily updates from infection control and practice guidelines. So it would be easy to forget these steps of adaptation that were sort of happening at such a fast pace. And it's so valuable to capture the experience of chaplains only 6 months into this pandemic, and further to be able to collect so many responses, the 1,654. So it's really great to have that important measure of this early first wave of the pandemic. The study, you note the emergency, this pandemic, it tested and challenged the field of spiritual care. And as the medical crisis unfolded, the spiritual domain became, as you say, a casualty of the crisis. And so I see the study is able to name the chaplain's experience of knowing the importance of spiritual care, although maybe not particularly clear about their role, but knowing the importance for patients and families in such a time of loss and suffering. And at the same time, many experience marginalization as a non-essential service. And so I too picked up on that. You used the word, the quality of moral injury for the chaplain. And the chaplain that understands the benefit they can offer in this situation, and yet are not at the table of those in charge who have the authority to decide how staff will be used in the face of the crisis. This is the frustration I hear in the extended quote. I think the quote was of a 54-year-old North American chaplain who said, chaplain leadership should have been at the table during the discussions of how to manage the pandemic. So it's clearly a theme expressed by many chaplains in this past year. The stated goal of the study to understand how chaplains delivered spiritual care during the COVID-19 global pandemic in order to produce important learning for the field, the learning of where spiritual care had overcome the barriers and provided essential care certainly will be helpful for replicating going forward. Examples of the resilience and other ways that we found ourselves integrated into the team and actually having a greater, that experience is quite powerful. And also, as you note, where the spiritual care was marginalized, to learn what was a factor so that it could be avoided in the future. I believe this study is well on the way to attaining these goals and garnering examples of what chaplains did during the pandemic and examples of where their roles were limited and considered non-essential. With respect to the key findings, the survey identifying that role confusion is quite amazing to me. And I think your hypothesis or wondering is how that's tied to leadership and not just the chaplains, but within our place within healthcare settings. The clarity about the role was not limited in the chaos of the emergency, but evident after, but even before, is quite amazing to see that. It's particularly revealing about chaplains and their profession. You know, I cannot imagine physicians or nurses expressing a similar lack of clarity about their role. In my setting, they were redeployed to areas unfamiliar to them, floor nurses going to the ICUs, but I still didn't hear that sense of not knowing what their role was. So that's amazing to see that. With respect to the creativity and the use of technology and our resilience, I think that's going to be a rich area going forward. I look forward to what I imagine could be a catalog of innovation and uses that will be rich for us to mine. Of course, I was particularly struck by the evidence in the article related to belonging to a professional organization and the benefits that will have for the field. So increased experience of support, and those belonging to the professional association having more regular supervision or intervision, and just the other support provided by associations. With respect to the question about being better deployed, I could hear the frustration there, identify with that as well, and perhaps also thinking about how resources were devoted to staff support, and wondering if the frustration was in terms of being limited in what you could do, or not yet discovering the creative response to reach out and be available to the staff. This to me could be a central area to explore for future understanding of the role of spiritual care in times of emergency. Perhaps the appropriate role of spiritual care in an infectious pandemic is to devote larger resources of time and attention to the frontline workers, nurses, doctors, housekeepers, food preparers. And that's just maybe that's just a natural shift that is made in our protocols. I made a note that I was somewhat surprised in terms of the greatest impact, that there was not an indication of the impact of fellow coworkers becoming sick, or also then becoming patients and some even dying. Could be that was, I don't think that was a specific question asked, but I would be curious if that emerges in the theme of the text analysis that happens. A couple of comments, just thinking about other future studies. One of the things I was curious about was if there were any healthcare chaplains that were in military hospitals, and if there was any greater clarity about role with those that serve in a more hierarchical structured setting. Just curious if that might be something that we find in the information about. Also curious about the other soft sciences in healthcare, the psychosocial fields, and were they challenged in similar ways in this crisis? Did they establish themselves as essential, or were they also casualties of the pandemic? Not within the scope of this study, but maybe for further study. And then just in conclusion, I think the study demonstrates the need for professionalizing the role of chaplains. A clear gap in healthcare systems is the lack of standards that apply to all chaplains. Minimally, this could include belonging to a professional association, or I think in the author's words, compulsory professional registration, and further establishing practice standards accepted in healthcare settings. Within the Association of Professional Chaplains in the US, there is a growing realization that we have a responsibility to reach out to all who carry the title chaplain, and not just board certified, but anyone wearing that title, and to offer creative ways to develop and raise the level of practice wherever we can through education and developing pathways that bring chaplains in. And I think the study demonstrates the minimal value of providing professional support, and perhaps to an improved clarity about role. So in conclusion, I just want to express my gratitude to the Chaplaincy Association networks around the world that collaborated and supported this important study. It is a testament to growing awareness that spiritual care has a role to play and service to offer in the holistic care of persons, no matter where they live on this planet Earth. Thank you.
Excellent.
Thank you, John. That's wonderful.
Anne and
Yes.
Austin, you want to respond to some of John's questions?
Yes. I do. I just want to start with saying that in the free text boxes, it was the first wave, and that might have made a difference regarding team members becoming sick or dying. because there was not a lot of talk about that. Some chaplains expressed their concern about the loss of a feeling of safety, and some mentioned becoming sick themselves, but it was not a major issue during the first wave. I cannot say that it was frequently found in the free text boxes, and that might be due to the fact that we are referring to March and April and the beginning of May of last year. So no. I forgot to mention also that regarding staff support, that we also have an article regarding staff support where we are putting the things that we read in the free text together around staff support. And indeed, I think it's very important to support the frontline workers. Another thing that regarding the membership of professional associations, there's also the aspect of the fact that those who are currently a member of professional associations usually have higher degrees of education. And that's an important factor also to take into account regarding your last remark, that you want to be there to raise the level of education of every chaplain, whether board certified or not. And then just another thing that I just want to remark, because Trace also wrote a concluding part for the Journal of Pastoral Care and Counseling. I think that out of this survey, we can conclude that it's also very much important for the future to look at chaplaincy from an international perspective, as we see that these three continents shared so much, that they had the same issues, the same challenges, the same problems, the same resilience, the same creativity, that it would be a shame to not progress on this international path of making ourselves and our profession stronger through an international lens. That's what I wanted to add to, and what Trace, I think, is exploring a little bit more in his contribution, that I wanted to add to my responses. Austin, do you have other things to add?
I don't think you've left me very much.
The veterans.
No, and thanks again to John for that fantastic response as well. I was very impressed by the depth of reading that you've done there. So that's you've certainly got to grips with exactly where we are. And I thought your comments on the military chaplains was a really interesting one. I don't know if we've got a subset big enough in our sample, but we'll definitely have a look to see if that's to see if they're more clear about their roles. I'd be really interested to see if that was the case. And I completely agree that I don't think you would ever get that level of doubt from nurses and doctors. And the other thing was, yes, the other softer professions. I was trying to think of someone comparable to a chaplain, but I'm struggling with that, to be honest. But I think that's also a good point, to see if there were other healthcare professions that maybe are seen as extra as opposed to essential. I don't know. Maybe there are, but I agree with your conclusions as well, John. That certainly the leadership and professional issues are probably important, and just to agree well with both you and Anne to say that these are in fact international issues. That was the most striking thing about this whole thing, was that the differences were in demographics only. When it came to experience of the pandemic, there were far more similarities than there were differences between the continents. Mm-hmm. So no, thank you for your attention and for listening so closely.
Thanks to both of you for the responses. We have a couple of other questions out there. We did not ask about other professions, as you noted, Austin, but Ian Cullen wondered about a comparison to social workers, if there might be some interesting pieces there. I think that might actually point to some good follow-up research. I think there's certainly an opportunity because the waves keep coming, and now with the onslaught of the variants, there may be more opportunity for further study as we go forward. Several people talked about how difficult it is to hear about chaplains' lack of role clarity and also the lack of understanding within administration, and then the need for advocacy within the organizations for chaplains to step up and really claim a place at the table. Peter Gelfner just posted a moment ago that if the administration doesn't know how to use chaplains during the pandemic, then they won't know how to use them after the pandemic. If there was ever a time, this is it. Some of us as associations have been collecting news articles and stories. Ian also posted a spreadsheet for those that would like to look in the question box. He's put a link out there too of over 100 different media reports related to chaplains. It is arguable that chaplains are having a moment and chaplains are also having a moment. I'm curious if you all have thoughts based on your immersion in the data, what the next best step would be for a chaplain that is trying to help their administration understand where to go, what to do.
Ooh. And that's a beast of a question.
Yeah, well, I wish I had kind of a general recipe that will cause miracles for everyone, but I don't think that exists. As Austin is saying, we're building the evidence, and I think evidence-based information is what is needed. That's one part of the story. I think evidence-based information is needed. We're building that up slowly with our different research, international researchers, and we know there is a sense of urgency there, but I think everyone is doing what they can. But inform yourself on results from research and try to translate that to your managers, to your leadership. That's one aspect of the story. Second of all, what I found very interesting in the survey is when staff experiences spiritual care themselves, it has an effect on integrating chaplains. That is something that we need to research maybe more, but we also need to take that into account as chaplains, that staff care is not lost patient time. It might take care of some effects that we couldn't foresee and we will be grateful for. And third of all, I think stories are important. Stories keep being important to tell your management or leadership. Concrete experiences of patients, the patient's voice in all of this is also very important. And we hadn't had a chance to put a survey out for patients only on chaplaincy during COVID, because that would be interesting too. But wherever you can and you have stories, narratives, case studies about patients or residents, I would say of course, with the consent of patients and the necessary precautions, this is something that is important towards leadership too. And I think we should start, that's my last element, we should always start from the fact that we are worthwhile, that we do make a change, that we're not the bottom of the food chain, that we're not the casualty of the pandemic, because every day we make a difference in the lives of patients and family members. And this is something that we should keep and stand on when we need it, also in difficult times.
Thank you.
I think I would just, I mean, that's a completely comprehensive answer. And I would just add, as a non-chaplain, I guess the only time you become aware of chaplains is when you need one. And there is no, it's like we're doing research at the moment and we have to include service users on our panels so that we create a protocol together with service users. Who is a service user of a chaplain? They're not like people with, mental health issues who can come together, or people who've had cancer or kidney issues. There is no bunch of people for whom spiritual care is a consistent and long-lasting intervention. And so it's really quite difficult to even get the patient voice together, because the patient voice changes all the time, and there is no consistency there. So I would go back to what Anne said in the beginning. You have to demonstrate that chaplains are worth it and that they're important. And to do that, I think you have to engage in the research. Whatever level that is, you have to present evidence because the evidence is increasing and improving for the impact of chaplain interventions. And so that's where you need to be. That's where I would start. That's what I was thinking about while Anne was talking.
There are several good comments as well in the question box of folks making suggestions as to how to make that happen. Susan Beverin from the UK noted as well that how chaplaincy is embedded within different contexts is also significant and important. There are a number of questions and encouragements for following up to see if in the second and third, and some places already thinking of fourth waves, how chaplains have learned and what sort of changes they've made based on the data that we saw in the first wave. So I think some encouragement of, well done, good people. Hey, let's do it again, and begin to build on what we've been able to accomplish here, because it's certainly an early start. Also a good challenge to drop the language of soft skills for chaplains, because those who've been through plenty of training know that it ain't soft, and as long as administration thinks of it as soft, it's going to continue to marginalize it. So figuring out language for ourselves to talk about this seems important too. We are at time. I just want to offer a minute if there's any final comments that any of you all have, and then I want to make one more reminder about the journal. Parting shots, Austin?
Thank you for inviting us. It's been a pleasure. And these events are always real important to get feedback and to get responses to your work. And it's I really appreciate being invited. Thank you. Makes me think, and you've made me think, and that's good.
Thanks, Austin. Anne?
That's quite a defeat to make Austin think. No, I don't have anything to add. Thank you for your hospitality and especially for the cooperation. And I'm hoping that everyone will be interested in reading more and more extensively, because that will inform us all, I think. So thank you.
Thanks, John.
Thanks for the great work, and it was great to be with everybody today. Great to work internationally. Thank you.
Yeah.
Yeah, thank you. Please keep your eyes out. We'll ask Transforming Chaplaincy to send you out a link as soon as the journal is available. We're very excited for what's coming, and we look forward to your responses to the work. Thank you again to Andy and to George and Transforming Chaplaincy for hosting this gather, for the support from the Chaplaincy Innovation Lab as well. Please take time to look at Transforming Chaplaincy's website and the lab's website to be able to see other webinars that are coming up. But in the meantime, watch your email for an announcement about the journal being published, and you've given us good things to think about and work to continue to do. We are building a field together. Thanks so much for your interest, for the 300 of you that joined the call today. Have a great day.
Thank you.
Thanks, Trace.
Thanks, Trace. Thanks, everybody.
Good job, guys.
Well done, team.